Good evening, everyone, and welcome to Cancer Connections. I'm Diane Munch, the Director of Professional Practice at Lurie Cancer Center, and I'm excited to welcome you tonight to our virtual education series, Cancer Connections. Our program topic this evening is cancer survivorship, and we're really excited to have experts from our survivorship team to explore the topic of oncology survivorship with our participants. We'd like to thank our advocacy partners whose resources were featured on the event webpage from 5:45 to 6. We hope you had a chance to learn about some of the support that they provide to our cancer community. As the program starts, just so that you're aware, your audio and video will be stopped. And we would like to encourage any questions that you might have during the presentation be put in the Q&A, typed into the Q&A box. And we will stop at the end of the first presentation and address any questions that are there in the box. And again, after our second presentation. So be assured that your questions will be addressed. And then finally, if you're having any technical difficulties, if you'd like to send us an email at cancer.northwestern@northwestern.edu, we'll try to help you with those difficulties. And with that, I am going to introduce our first speaker. Our first speaker is Dr. Kinahan. Karen is a nurse practitioner at the Lurie Cancer Center, and she has spent her entire 35-year nursing career in oncology, first in pediatric oncology, and for the last 25 years, Karen has specialized in cancer survivorship, which currently includes managing the adult survivors of childhood cancers in our STAR program, but also providing survivorship care to adult onset cancer patients. Karen's here today to talk about how survivorship has developed as part of the oncology patient care continuum here at Lurie Cancer Center, and specifically her role in development of the program here at Northwestern. So welcome, Karen. Thank you for being with us tonight.
Thank you, Diane. And let me share my screen, which I think you'll still be able to see me. Let's see here. Okay. So hopefully you can hear me now. So thanks for the introduction, and I'm really happy to be here, and I'm glad we're covering this topic of cancer survivorship because I'm very passionate about it. Been working in this field for a long time. This will be a two-part talk, and I'm going to be covering the evolution of Lurie Cancer Center's survivorship care programs at Northwestern Medicine, and I have some objectives I will talk about first. So the first thing I'm going to do is also describe the history of cancer survivorship, because I think it's important to understand, kind of where we've come, even in our country, et cetera, about with cancer survivorship, and then which led to the development of the programs. I'm going to talk about some key research studies from the Childhood Cancer Survivor Study at St. Jude, discuss the evolution of the survivorship programs at Northwestern Medicine, and then explain how primary care providers play an important role in your survivorship care. So first, the history of cancer survivorship. So back in 1986, the National Coalition for Cancer Survivorship was founded. And you might have heard of this NCCS if you look this up online or on the website. But this is really where survivor and survivorship were defined. This is a survivor-led movement, and there were many physician and nurse champions back then. And in this picture, which is here, a little bit hard to see, but many of these people who were also patients were physicians and nurses, and they really wanted to get this program going. So their goal was to deal with the full spectrum of survivorship issues related to living with, through, and beyond a cancer diagnosis. And to advocate for quality care for all people touched by cancer. So that's the NCCS. About 10 years after that, there was the establishment of the National Cancer Institute Office of Cancer Survivorship. This is created during the Clinton administration and in recognition of the growing number of cancer survivors during that era. And their focus is a little bit different. It's charged with expanding, directing, and championing cancer survivors of research and education. So these two organizations are still up and running today. So some definition of the cancer survivorship and cancer survivor. I thought this might be useful to kind of go over some of these terms. So cancer survivorship, this phrase was created to describe this broad experience of the cancer continuum, actually, with living, as I mentioned, with, through, and beyond a cancer diagnosis. Cancer survivor is a little bit different. The individual is considered a cancer survivor from the time of diagnosis through the balance of his or her life. And family members, friends, caregivers are also impacted and are therefore included in this definition. And that might be a little surprising from the time of diagnosis. I think this has been the more widely accepted definition for a number of years, but this is just the way that this has changed. And I think people will say, oh, I have to get to my 5-year mark or 2-year mark or off therapy before I'm a survivor. But when indeed you're a survivor from the time of diagnosis. So there are many cancer survivors, including that are living with cancer, and then those are free of cancer. But the term is really meant to capture this population of those with a history of cancer, and not to provide a label that may or may not resonate with patients. And every now and then, somebody will say, I'm not sure how I feel about the word survivorship, or what does that mean? And I always like, this is your journey. And if you want to call this the aftercare clinic or something, that's fine. And that Melissa and I, we've discussed this, we don't have any issues with that at all. So the other thing I'd like to talk about is just really kind of going back, starting in 1994, where the Child Cancer Survivors Study was funded by the National Cancer Institute. And this really gave us a lot of research and outcome data that we learned a lot about, like what's happening to patients when they're done with treatment. So this is a very large study. It's a retrospective cohort of child cancer patients. So in that case, it would be patients basically diagnosed at 21 years or younger that were treated early from 1970 to 1999. They have 31 contributing centers across North America. Each of these have at least a 5-year survival rate, and the cancers are a little bit different than, not like breast and colon cancer, but things that we see in childhood, adolescent, young adults. So leukemia, lymphoma, brain tumors, bone cancer, Wilms tumor, neuroblastoma, and soft tissue sarcoma. They have very detailed treatment information, and there's been a wide range of outcomes. And you can see the large number of patients, 35,000 eligible. There's over 24,000 participants. They have sibling cohorts for the control group, and then stored DNA. So a lot of information has come out of this study. One of the key studies was this chronic health conditions in adult survivors of childhood cancer. And this was published in 2006 by Dr. Kevin Effinger, who is now over at Duke. And this is one of the first studies that had this data from the Child Cancer Survivor Study. So over 10,000 survivors who were diagnosed from 1970 to 1986. And they were at the time of this completing the survey, 18 years post-cancer diagnosis. They also had a little over 3,000 of sibling controls. And what these patients did and survivors did was grade health conditions that they were having using a tool that's an NCI tool called the CTCAE. And I'll just talk you through this a little bit. So the grade health conditions, and a grade 1 condition would be something that's mild, something that's just asymptomatic or mild symptoms, and really just observation is needed, no interventions are needed. A grade 2 condition would be a little more moderate. Maybe now you have a cataract that requires surgery, or you have abnormal pulmonary function tests as an example. Grade 3 is something more severe, limiting your self-care, or maybe interfering with activities of daily living. So maybe now this is a thyroid nodule that is developed that needs surgery, or you're having muscle weakness on one side and having trouble, caring for yourself because of that. Grade 4 is something life-threatening or disabling, such as stroke or cardiac arrest. And then grade 5 is death. So again, this is published in the New England Journal of Medicine. And I remember when this came out, it was kind of a big deal, actually, because it was one of the first large studies. So I have a lot of slides that go along with this study, but I wanted to just talk a little about this one, because this is sort of a summary slide where we have on the bottom here, years from diagnosis up to 30 years, all the conditions, grades 1 through 5, and about 70% of patients have one chronic health condition, or said they did. And then the higher grade conditions, about 40% of these patients have these higher, more severe grades. So the other thing that was telling about this slide and this data was that these late effects of therapy, or effects from therapy, aren't just increasing or plateauing or decreasing with age, but they're continuing to rise as the patients were farther out from their cancer treatment, which really then kind of hit home in the child cancer world, saying like these patients that are survivors really need ongoing lifelong follow-up care. A secondary analysis was looking at the more of the life-threatening and fatal events in child cancer survivor study. And this one looked at just the higher grade conditions. This is by Dr. Greg Armstrong, where the survivors will have about at age 50, so they kind of used age versus years past diagnosis. The 54% of the survivors by age 50 would have a higher grade condition, and compared to about 20% of the sibling control. So a significant difference in these high grade conditions as a patient's age. The cumulative incidence of these organ systems. So you can see here that, they looked at renal and hearing and vision and respiratory, and the red is the survivor and the yellow is the sibling. So there is a difference in each of these, more so, having higher incidence with the survivor. But the two that had the highest incidence and the more significant difference was new malignancies and cardiac late effects. So this would be something, maybe a new, secondary breast cancer due to radiation, cardiac effects with anthracycline or chest radiation. And these are two areas that we pay a lot of attention to in survivorship. So I want to talk a little bit about some language or lingo, medical lingo, because I'm kind of interchanging these words, and just want to explain to you the difference between a long-term effect and late effect. So some long-term effects will become evident during anti-cancer treatment. So during treatment, patients might develop an effect of neuropathy, which is maybe the platinum drugs or Taxol, and then cardiomyopathy, which is from anthracycline chemotherapy. These problems can range in patients mild to severe, or some can be debilitating or even life-threatening, maybe in the case of cardiomyopathy. And some of these are temporary and will improve with time, whereas other effects, long-term effects, might be progressive or permanent. Whereas a late effect is something that might not manifest for months or years after active therapy. So this would be an example of maybe a secondary skin cancer, 20 years later in an area of radiation, or even that cardiac effects, as I mentioned on that slide, that can happen as patients age and years go on. So a lot of screening tests can be done, and patients can be surveilled for these with like echocardiograms, with dermatology skin exams, colonoscopies, as an example. And a lot of what we do in survivorship care is understand the patient's risk factors by knowing their specific treatment that they had, and then performing a lot of these follow-up tests and getting you into, for example, a dermatologist for a skin exam if it's something we think you're at risk for. So going back a little bit to a little bit of history, in around 2003 or so, there was the Institute of Medicine, there was a call to action, and the Institute of Medicine is like the founding father, so to speak, of medicine in our country. So they recommended back in 2003 that we should develop evidence-based clinical practice guidelines for the survivors of childhood cancer. And these were published and put out on the web at this right here, survivorshipguidelines.org. And these are still available today. A really great resource, in fact. So the bigger issue that became more evident as patients were surviving again still was this booklet, which is actually a symposium summary that was through the ILM. It says, "From Cancer Patient to Cancer Survivor, Loss in Transition." And some of you might be familiar with this already. But this was, they got together to just, again, talk about, wow, who's taking care of all these people surviving, and who's responsible for what, and what's the best, models of care, et cetera, that we could be doing. One of the things that they said were that cancer survivors swell in the ranks of many places where we live, work, and play. As our committee concluded, they remain largely understudied and lost to follow-up by our scientific research and health services delivery communities, respectively. And one of the other things they mentioned in this book, which kind of came out again in the press, was that risk-based long-term follow-up care is required for all cancer survivors. So this was really the push to kind of get patients, when they're done with therapy, into a follow-up kind of program for all cancer survivors. So some of the key areas that were outlined by the Institute of Medicine are as follows. So one of them is prevention of recurrent and new cancers or other late effects. So the prevention would be something like wearing sunscreen, stop smoking. Those are things that we can do for prevention. Surveillance of cancer spread, recurrent second cancers, and an assessment of medical and psychosocial late effects. So this would be perhaps when you're off therapy, you get some scans, or following with mammograms, et cetera, things like that. And secondary cancers are some of the things we do based on the patient's risk factors to screen for secondary effects of those second malignancies that I showed you on that slide. So, and then important to not forget or talk about is the psychosocial late effects. And I know that this is something that Melissa and I talk about at every visit. as we do a review of systems about mental health and, how you're doing. Are you, need any help, having anxiety? So it's something that we do bring up at every visit, and it's important to not sweep that under the rug. Interventions for consequences of cancer. So that's so patients, when we find issues, we get them into the treatment that they need, which also involves a lot of coordination between specialists and primary care providers that's involved in the survivors' healthcare. So that is a lot of what we do too in survivorship, because just, A, helping patients get to the right specialist, and then B, getting the information of what we put together for the patients. We send that to the primary care provider. If you don't have one, we try to help you get one. And then they also identify the necessity of this treatment summary or survivorship care plan. So we'll talk more about that. Melissa's going to cover that. And then that this care plan or survivorship care plan would be a roadmap for post-treatment care for both the survivors and primary care providers. And then this should be created by the oncology treatment team. So we'll talk more about how that shook out. So what are we talking about when we talk about health concerns after cancer? So I'm going to use my cursor here. We have cancer in the middle, and just going to the left here, we have psychosocial effects. And I think everybody, any age, is somewhat affected by psychosocial effects. So changes with mental health, maybe education is abrupted. If you're in college, you need to come home. Employment can be impacted. Social interactions can be effective. Chronic health symptoms, and even also physical and body image concerns. As far as subsequent cancers, we deal with recurrent primary cancers, but also new primary cancers. Fertility and reproduction, I feel like we are doing so much better in this area with fertility and health of offspring, and probably could do a little better with sexual functioning, but that's something that also needs to be considered and talked about. And then organ function, there's many organ systems listed here: cardiac, endocrine, GI, which is more of a liver, genital urinary, musculoskeletal, neurologic, pulmonary. We hope that all the patients don't have all of these issues, but these are some of the key organ systems that can be affected by cancer treatment. And then the other thing is just growth and development, and that's probably more pertaining to our younger population, childhood cancer, where we have problems with linear growth or intellectual function. So going on to all of that, kind of what has happened then at Northwestern was established in 2013 is when the Cancer Survivorship Institute had come to play. And I was reading a press release because I was trying to remember the date of when this started. So I did copy and paste the link, the website for the Cancer Survivorship Institute. And if you have, Diana, I think is going to publish these slides, but if you just went to cancer.northwestern.edu, you would see, you could type in survivorship, and you could get to this page. So the goals that we have of as we call it, the CSI, is to integrate high quality clinical survivorship care with innovative research so that we better understand and address the unique needs of cancer survivors. So some of you might be involved in research studies that we're doing at Northwestern that are not necessarily treatment research studies, but maybe after treatment, like there's ones for weight loss or breast cancer and exercise, and a lot of stuff going on with that. Our clinical program is to help and treat the physical, psychosocial, practical, spiritual, informational challenges that occur during cancer treatment and can persist long after active therapy. So to that, I'll say, as we just mentioned, we do try to cover this, but I feel like sometimes when we meet with patients in clinic and now they're done with treatment and we have our time together and we go through everything, they're like, okay, now I get it. Or they might even become more anxious after treatment's over because now they're done with that, and now that's the next phase of their care. So that's something that's very common. And then also to mention that Northwestern has survivorship services that span across the regions. However, models of care will vary by practice location and disease type, and I'll explain that in a second. So kind of a neat slide here with the kind of age of trajectory here, and the programs that are kind of housed under the Cancer Survivorship Institute are these. Oh, this did this every time to me, sorry. The STAR program, we have an AYA program, the Lynn Sage Breast Cancer Survivorship Program. And I wanted to mention the Northwestern Medicine West Region, North Region, and the Kishwaukee. So I'm going to speak generally to what we're doing downtown, but these sites do have some survivorship care involved in their sites, but their models might be different in the sense that they might be doing this for certain disease types, like into the actual visit with their providers, the patient's providers, versus a separate appointment as we do it downtown. So just to mention that, if you have questions, you can ask those. All right, so downtown at the downtown campus, we call it the Central Campus. I'll kind of go in order here where we have the STAR program, which is it's called Survivors Taking Action and Responsibility. It's a program I actually came to Northwestern in 2001 to start. So it is long-term follow-up care for adult survivors of pediatric cancer. So the criteria for the STAR program is patients that would be 21 years or younger at diagnosis, but we do follow patients for life. So we have patients that are in STAR that are 30, 40, 50, even 60 years old, but they all had cancer at 21 years or younger. We see them annually. It is a fairly transient age group in some sense. We have patients we've seen year after year after year, and other people can't come 2 or 3 years in a row, but might move away. We get other patients. Also mentioning that we do take outside referrals for this program. For example, if a patient was treated, say, in Memorial Sloan Kettering in New York, but now they're moving to Chicago for their job or something, that we can see them in the STAR program. They don't have to be treated at the Northwestern system or Lurie Children's. But we do follow these patients for life. And then the pediatric STAR program is housed over at Lurie Children's, and that's for patients who are diagnosed at a younger age, followed after curative intent therapy, and then maybe at about 22 to 25 years old, they'll be transitioned over to Northwestern, to our clinic. So that's the STAR program. The adult survivorship clinics, these are more disease specific follow-up care. We do have annual visits with patients, but these patients are referred by medical and surgical oncology teams. So that could be your medical oncologist, PA, physician assistant, nurse practitioner. When you're done with your treatment and they feel like it's a good time for you to come over, they will generally ask you, we have this program and we're gonna ask that you go and have a visit with us in this survivorship program. So in other words, I guess I wanted to mention too, we're not taking outside patients for this program. We just don't have the bandwidth to do that. But we, as long as part or any of your treatment is done at Northwestern, you are eligible for this program, right? When your providers will refer you. So the breast cancer program started about 2014, lymphoma about 2017, leukemia 2018, testicular cancer 2018. And then I put colon on there, colorectal. We used to see the colorectal patients in our general survivorship clinic, and several years ago that went back to the treatment team. But I still see some colorectal patients in my survivorship clinics, year after year. And if it's something that, as a colorectal patient, that you're interested in doing, you feel like you want to see what this is all about, you can ask your surgical or medical team to refer you, and they can put a referral in for that. And that's just done through Epic. And then we have the AYA program. So that's not a survivorship program per se, but it is under the CSI. These are for AYA cancer is for patients that are diagnosed between 15 and 39 years old. And it's international, it's nationally, or we have a really strong program with our AYA program. So they offer support services, chats, education events, meetups, they call it hangouts, and networking on AYA topics. And this has changed slightly with COVID because we used to do in-person visits, in-person events. A lot of them are done now virtual or through things, but they did have a Christmas party. And for our young adult patients, this is useful. And if you want to look into it, you can just actually probably search AYA program Northwestern Medicine. They have their own Facebook page and informational page about that. I also want to talk about survivorship guidelines. And as I mentioned, just as time has gone on, there are several clinical practice guidelines that are available, some of which you might be interested in looking at yourself. So ASCO, which is called the American Society of Clinical Oncology, it's probably the biggest organization for cancer worldwide. They developed guidelines that came out in 2013, and they're at asco.org. They focus more on some of these side effects or late effects from treatment. So information about, what is this, what do I do about this? And, some information with breast cancer, palliative care, fertility preservation. I mentioned the NCCN guidelines came out in 2017. We're an NCCN, which is called a National Comprehensive Cancer Network Center. And so this is really great that I was excited about this, and because this is more for the adult, folks that we're taking care of. And they also have survivorship included in that, and just stuff about cardiotoxicity that was not present before that. And then to go over again, the Children's Oncology Group long-term follow-up guidelines for childhood, adolescent, and young adult cancer. These are again at survivorshipguidelines.org. These are in the 5th version. These are evidence-based, so they're based on research and outcome data. So just a really good resource for if you're not familiar with it. And what they break it down is more like by specific drugs, so anthracyclines, doxorubicin, carboplatin, and then kind of like breaking down like what is the late effect, what are the follow-up recommendations. But again, these would be for patients, that are adolescent, young adult, or childhood cancer patients, more than not for necessarily like a breast cancer patient or a colorectal patient. And then the NCI, the National Cancer Institute, also has information about survivorship and late effects at cancer.gov. And so that I put the website for that. I also was looking at our own, the CSI website, again, cancer.northwestern.edu, and there's quite a bit of information about managing long-term side effects. So if you're not familiar with that, please take a look at it. Stuff about chronic pain, emotional distress, fatigue, so common issues. And then it also, on this left side of this page, would have, this is just a screenshot, but some of the information about the programs we have. So just take a look at that when you have a minute. And then survivorship care standards. This has been important sort of in the practice of providing and, putting out survivorship care for our patients. So going back a little bit here, back to 2006, I mentioned the Institute of Medicine Loss and Transition book. And that was the big thing, the big push, like every survivorship patient should have a survivorship care plan, and we need to do better. Well, not really a lot happened between here and here. And they put out another booklet that was called this Delivering High Quality Cancer Care, Charting a New Course for a System in Crisis. So I think this got the people around the country more paying attention to survivorship care. And then in 2015, a couple years later, an organization called the Commission on Cancer included survivorship in their 2015 standards. And the Commission on Cancer is an accrediting body that accredits such as the American College of Surgeons. So we, as a Northwestern American College of Surgeons organization, we need to be accredited by the COC. So when they started this, they said 10% of eligible patients completing curative intent therapy would receive the survivorship care plan. Then we have the NCCN guidelines, I mentioned that. And then 2018, this is now, they're ramping up this standard up to 10%, 20%, and now in 2018, it was over 50% of these patients, which stage 0 to 3 cancers who completed treatment should have this care plan delivered within 6 months. And breast cancer population also was included here now with their own organization, the NAPBC, where they said over 50% of eligible patients, stage 0 to 3, should again receive this care plan. So this became that survivorship care was just not a nice to do thing, but it's something that we had to do. And this is very stressful and hard on our organizations really around the country, because these are time consuming to put together. The visits are time consuming. And so there was a lot of pushback really around the country. So a little bit simpler plan now around 2020, and currently now the COC put out the standard 4.8, which changed that the survivorship program or team would need to document a minimum of 3 services for patients provided each year. So that would be documentation of, for example, a physical therapy referral, an echocardiogram, for example. The survivorship care plan counts as one also. Referrals to different services that you might need as part of your follow-up care. So this is kind of how we're doing it now and what we're tracking to be able to meet this COC standard. So I wanted to show this slide because I think everyone always likes to see like what are the top cancers. So this is the cancer treatment survivor statistics for January of 2022. A total, when you add these together, 18 million survivors. And then the top 3 cancers for male patients were prostate, by far actually, melanoma, and colon and rectal cancer. And then we have female breast, by far the highest, and then uterine cancer and thyroid cancer. So when you add these all up, it comes up to 18 million cancer survivors in the US as of January 2022. Another slide I wanted to show is this what's kind of concerned or called to be this epidemic of survivorship and the silver tsunami. So I'll just kind of go through this with my cursor. So in 2020, there were approximately 1.8 million people diagnosed with cancer in the US. So that puts us about here. And by 2022, there are 18 million cancer survivors, as I just showed you on the earlier slide. By 2030, kind of moving up here, there will be more than 22 million expected. And that by 2040, which is here, there are supposed to be over 26.1 million expected, but also 73% of these survivors will be older than 65 years old, which is where this arrow shows down here. So the green, purple, and blue fade. So when we're looking at a health system, delivery system, that, you know, it's a good problem to have, but when we have that many survivors, but also that are over 65, there tend to be just health comorbid conditions like lung disease, heart disease, diabetes, etc. So it's going to be, you know, a lot to deal with, and I think this is something that's being recognized now and kind of focused on and worked on as the years go on. So some of the challenges we have in survivorship care are this growing number of survivors. There's also poor integration of survivorship care between oncology and primary care, sort of the who's doing what. So I think you might have even felt this yourself, and when you're maybe done with treatment, that who's going to order your mammogram or who's going to a DEXA scan, especially if you're not in a survivorship clinic, somebody to kind of point you this direction and kind of help bridge that gap. There's also, in addition to this, a clinician workforce shortage of doctors, advanced practice providers, which are nurse practitioners and physician assistants, mental health providers, and also support services. So you might have recognized this even yourself if you have any time recently tried to get a primary care doctor appointment or a psychology health appointment for mental health. There's quite a bit of wait time now for to get in to see providers. There's also knowledge gaps that take place for cancer survivors. And there's really, in the adult side especially, a lack of strong evidence-based guidelines for post-treatment care. So I've heard primary care doctors say to me, just tell me what to do and I'll do it. Just what do I need to do? They want to be involved, but the primary care providers in general are trained in, diabetes, hypertension, things that they manage, and not necessarily anthracycline chemotherapy or alkylating agents, things like that. So this is just something that has been a problem for years and probably will continue to be. So that's why kind of this bridging and this trying to communication can help. There's also financial insurance and barriers to quality care. You guys probably know that better than I do even. And then we are more concerned now with healthcare disparities, including this, their gaps in early detection for cancer and access to high quality cancer treatment. So just to kind of run through some of these challenges, that we recognize and are working with. So one of the models I wanted to share with you, and this kind of gets some patient involvement too, is called the shared care for cancer survivors. And I actually did my doctoral work on this based on this model. So I'll take you through it here. And this is really the general gist of this, is that care is coordinated between the oncology specialist and primary care provider, or PCP. So this is the patient. They have a primary care provider, pre-cancer diagnosis, and then here's the cancer diagnosis. So at this point, a cancer treatment plan is made, and then the oncologist or this team now is going to be your main caregiver, right? Main player, because you're there for appointments and follow-up, et cetera. And you hopefully will have intermittent follow-up here with your primary care provider during this time. B here is when the treatment summary is developed and you're off treatment now. And I can speak for Melissa and I that when we write these treatment summaries and care plans, we at least try to send them to the primary care providers so they have this information sent to them. So the other key about this is when patients now are 1 to 2 years off therapy and you have less follow up with your oncology team, because as you know, maybe time sort of spreads out eventually, and you'll be transferring back here to your primary care doctor as your main provider. So A, it's important to have a primary care provider, but B, I think what I'd like to ask you to do is during these points of treatment, off treatment, follow-up visits, to ask your oncology providers, hey, would you mind please sending your note to my primary care provider? And it's generally, if we have it in our system, which is fairly easy to do, it's really the click of like 3 buttons to send our notes. So that's something I think that's just going to help better with the coordination for you, because if that doesn't happen and you suddenly come back to this primary care provider a couple years after therapy and they have no idea what you've been through, they're going to be a little bit shocked and really feel kind of out of the loop as to what happened. So the more we can communicate, during treatment and at the end of treatment and then ongoing, is really going to be to your benefit. And then the last thing I'd like to talk about is called the Cancer Moonshot, and with the tagline of End Cancer as You Know Today. So this is a national initiative, and the original moonshot took place around 2016 under the Obama administration. I'll just read this. This was back when in 2016, US Congress signed into law called the 21st Century Cures Act, authorizing $1.8 billion in funding for Cancer Moonshot that would be distributed over 7 years starting in 2017. So that's going to end at the end of 2023, the end of this year. They have funded, the NCI basically is who funds this, 240 research programs, 70 programs for patients in treatment, after treatment. And really a lot of the advancements we've made over this past 6 or 7 years has been due to this Cancer Moonshot. So their goals back then were to accelerate scientific discovery in cancer, foster greater collaboration, and improve sharing of cancer data. So, kind of not having silos of data, but share the data we have. So we all know what happened here, the pandemic, right? So I was really happy to see and read about this, that in early 2022, President Biden reignited this Cancer Moonshot with the general goals here, just 2 of them: to reduce cancer death rate by half within 25 years, and improve the lives of people with cancer and cancer survivors. So this can be found on the whitehouse.gov website. So how they're planning on doing this and the work that's starting is by using key stakeholders to come together and make progress in 7 pillars of how we know cancer today. So to make impactful steps to improve cancer screening, to enhance prevention, address inequities. This has been a big focus recently. And if you notice, these first 2 and even the other ones are very similar to the Institute of Medicine recommendations. 4 would be to target effective treatments to patients. So this would be things like targeted therapy, immunotherapy, things that we're using now, and maybe there's other similar patient, treatments could be used for other patients. Develop approaches for deadly and rare cancers, including childhood cancers. 6 is support patients, survivors, and caregivers. And then 7 would be to learn more from people living with cancer. And then 2 last things, there is a call to action on cancer screening, and this is to jumpstart progress. There are nearly 10 million screenings in the United States, cancer screenings that were missed as a result of pandemic. So getting people back in for their colonoscopies or mammograms, et cetera. And then the other key point here would be to work to ensure that all Americans equitably benefit from the tools we have to prevent, detect, and diagnose cancer. So that is my talk. I have questions, and I will stop sharing my screen because I think Diane will probably be sharing hers. So thank you for your attention.
You know what, Karen, you can keep that slide up, or why don't we just have you keep your, we'll have you keep your camera on, and I'll just ask you the few questions that are here. We had somebody ask a question about gynecologic follow-up for gynecologic cancers. Is there any
at Northwestern?
Yeah, Northwestern. Is there for gynecologic survivorship, so survivors of gynecologic cancers?
Yes, okay, so it's not one of the cancers that we see in our central survivorship, but Nicole Tasker, who's one of the nurse practitioners in the gynae oncology office in downtown Chicago, is familiar with survivorship. I think she did it at her previous job, and so we'll do survivorship visits. So that's something to ask when you're going in to your providers and say, what kind of services, and if it's not going to be a full appointment, that maybe it would be at least some information, some networking, some groups or something that would be helpful to patients when they're done with treatment. So, and as far as the other sites, I am not familiar with like the North and if they are actually doing full on like survivorship services for gynae oncology. I guess the best thing to do would be to ask the providers that you're seeing if you're up at one of the other regions to see, what's available to you. But regardless of that, I think it's worthwhile for all patients, as kind of just what we talked about and what Melissa's going to talk about, to ask for a treatment summary or just a list of the drugs you had, or maybe you're good at keeping track of that and have that already. But I think this knowledge of getting this information together for yourself, so when you're looking up, topics of what are some of the late effects, et cetera, if there's not a full survivorship visit for you, that at least the treatment you had and what to ask for or what to look for.
So I have a question about, so I guess at the beginning of the presentation, you mentioned that survivorship actually is a continuum from the time of diagnosis, and someone asked, can you get survivorship visits if you're on treatment, if you have treatment?
Oh, that's a good question. So I see the point of asking that question. So we will see patients when they're done with curative intent therapy. So that means, for example, patients maybe with Hodgkin lymphoma who had their chemotherapy, radiation, may or may not have radiation. But when they're done with like the treatment portion of their care and their scans are looking good, that's the time to have a survivorship visit. The exception with this might be a little bit confusing with breast cancer patients who are on hormone therapy for 5 plus years with an anastrozole or tamoxifen, et cetera. So we will see patients that are continuing on hormone therapy for breast cancer, but they are done with maybe perhaps a surgery, radiation, or chemotherapy that they received. So hopefully that's clear. So I think it's best to get through the treatment first, kind of wrap your head around that, and then ask kind of what's available to you on the survivorship scene after you're done with that treatment.
And then this is just kind of all the symptoms you mentioned that in the things that you showed, the diagrams you showed, what do you see most frequently in your clinic as troublesome survivorship or long-term symptoms?
Late effects. Well, I have to break it down in a couple different things. So in the STAR program that I've been doing for almost 2 years, definitely issues more endocrine related, like hypothyroidism, secondary thyroid cancers, cardiac late effects are common, not common, but common enough that we do very rigid screening for echocardiograms based on the Children's Oncology Guidelines. So I'd say cardiac, endocrine, and then just in general, not what we see, I haven't really done the data, but a secondary skin cancer is actually one of the #1 secondary late effects due to radiation. This doesn't happen overnight, and a lot of these cancers don't occur overnight either. It could be 10 plus years, but skin cancer in particular is actually the most common. And so that's why it's really important when we have patients that have had radiation, especially at a young age with the STAR program, that we get them in for a very good, thorough dermatology skin exam called the total body skin exam. So that's probably, if I had to add them up, that'd probably be #1, and I think nationally that's like #1. But definitely the endocrine and then other cardiac effects as well.
I know you mentioned some of the specific cancers that are treated in your clinic, and there was a specific question about myeloma. Are there survivorship visits for myeloma, or are those covered in the stem cell survivorship clinic?
I'll have to ask Melissa about that. There's not a specific myeloma survivorship program. And I guess the question would be, is if that's something we should start down the road with, if there are enough patients that want that, and that's something that their providers could address with Dr. Kircher or with Melissa, even she knows a lot of them too. So, but as of now, there's not a formal program for myeloma.
Okay, we'll hold that, maybe pose it once again. And then just the last question I was going to ask, because we have to move on, is do you have any...
Oh, I think you cut out, Diane.
Oops, sorry. Do you have any recommendations about people that are looking for survivorship resources at some of our partner hospitals? Is there somewhere someone they can contact or who they can call?
Oh, that's a good question. Well, I know the names of people, but I wouldn't know like how to get a hold of them at like Kish or at the West region or North region.
So why
Um,
don't we could leave it as, we'll refer back to your survivorship page on the website and see what we can collect there. And certainly if somebody was speaking about outside the central campus, we can try to address the question through the website. But if the person who put this question is asking about hospitals outside of Northwestern, that's obviously something they'd have to check with the hospital, but also all those resources that we had in our virtual resource list when we first started. I think all of those organizations can connect people with survivorship resources for sure.
yeah, can I just add one more thing? Because this is more in the general community, and we do give information during our visits too. But the cancer wellness programs, I think that's what you're referring to, Diane, which are in Homewood, Hinsdale, the West region has one out in Geneva, Northbrook, and those are more in the community, where I just referred a patient to one in Homewood yesterday because she was looking for meditation and services, and she lives down south. So I was able to like just connect her with that. And these are really places where you can go get some good support and information, generally free of charge, and they're here to support you more in the community, which is probably better than coming downtown anyway. So just want to share that with you. So just the cancer support community, and we can also maybe include that in the slides. So you can share that with them, Diane, when you share the slides. I can get the printout for that.
Yeah, we'd be happy to do that. Thank you so much, Karen. We really thank you for the presentation. We didn't get to all the questions, but I'm going to try to scroll some of these to Melissa, but I'd like to give Melissa time to get online and get started with her presentation. So thanks very much.